And it is with great pleasure that I introduce Sue Thomas, whom I first met at the RCN, who's now Chief Executive for Neurological Commissioning Support. Sue.
Thank you very much, Rowan. And it's good to see you here this afternoon. We're quite a small group, I think, but that's pretty usual for neurology and the work that we do, because of course neurology is definitely not on the commissioning agenda at the moment, and so we were delighted that we're able to come and do this presentation to the few of you, but I hope that we'll convert many more as the months go past, and we've now got a new national director for neurology, and neurology starting to get onto the profile. What I want to do is talk to you a little bit about the work that NCS has been doing with some of the CCGs that we've been working with, and just really try and get you to think a little bit more about the neurological conditions in the areas that you work in. I'd like to thank UCB again for supporting this session. But for those of you that don't know anything about NCS, we're a fairly unique organisation. We've been formed by 3 national charities, Parkinson's UK, the MS Society and Motor Neurone Disease Association. And we have an affiliate member in the Epilepsy Society. And those charities came together because they really felt that they needed to influence more at a local level the commissioning of services for people with those conditions. We are supported by those 3 charities, but we work across the whole of neurology when we go to work in an area. We're experts in neurology solutions, and we're working to try and improve outcomes for patients as well as drive costs down. We're not for profit. We put service users at the heart of all the commissioning that we do, so it's very much from a patient perspective. And we've been very fortunate to get 2 different streams of Department of Health funding in order to support the work that we're doing. Our reach from our collective partner charities is around 83,000 people who are living with Parkinson's, MND, MS and epilepsy. So that's quite a broad range of service users there. And just to look at the 9 areas that we've recently been working in, we've been working with PCTs, local authorities and CCGs. We've been working with a group of 1 million people that have got neurological conditions to try and influence their care. Just to put neurology into context, neurology's always been a fairly low-profile condition, even though it's number 8 in programme budget spend, which you might not realise. There's been a 38% real-term increase in annual spending since the National Service Framework for Neurological Conditions came out in 2005 and between 2010. But even though there has been investment in terms of funding for neurology, services had not improved. We lobbied the National Audit Office to do a review of neurology services, and their review showed that there'd been a 31% increase between the NSF coming out and 2009-10 in terms of neurology inpatient admissions. The real startling thing, though, was that emergency admissions for people with neurological conditions had risen phenomenally. 32% increase between 2005 and 2010, compared to 17% as a whole for the NHS. So that's a huge increase in the number of people that are going into hospital because of their neurological problem. Just in terms of expenditure out at a local level, there is a huge variation in the amount of money that PCTs were spending on people with neurological conditions. And if you look at the highest expenditure, that was in central Lancashire, where they were spending 11.37 million per 100,000 of the population, compared to Haringey, who was spending 4.31 million. So that's meant that there's still a significant postcode lottery in terms of services for people, with nearly a 7-fold variation in the proportion of expenditure on non-elective inpatient and urgent care admission. How do we help locally? Well, what we try and do is go into an area and actually develop a baseline picture of what services are like in that health economy, be it a CCG or a provider. We provide a quality neurology audit so that we can look at how services are performing, and we can benchmark that area against other similar sized areas so that we can look at how they're performing in comparison to other CCGs. A lot of our work revolves around looking at data and seeing what the current position is. Then we'll try and work to integrate care in a more robust way and look at improving patient outcomes and driving costs down. This picture here is our handbook for Norfolk. We just finished our initial work there, where we've done a whole review of the services, and we've provided them with a template for action that they are now taking forward between Norfolk CCG and the local authority there. But what we try and do is have a look at what's happening in practice, really try and understand what the good practice is and how that can be disseminated elsewhere, and then look at quick wins and more longer-term aims in terms of trying to redesign services and provide transformation. The whole of the work that we did there was in partnership with the whole health economy across health and social care, with tertiary care, with independent providers, and we did consultation with more than 1,000 patients in the area who were living with a neurological condition. What we try to do when we're in an area working is do a process of shared decision making with patients, so they are very central to redesigning the services and do co-production. Patients themselves don't want to be dependent on healthcare services. They want different solutions. Very often they want things that the area is not providing, and they're quite ready to make decisions about where they're going to have to redesign services, where care may need to be rationed, how it needs to be delivered in a different way. So they're very open to working in order to reshape the services. As a result of the work that we've been doing, we've put together a 10-point plan for better commissioning in neurology services, which gives some just broad themes that you can focus on in your CCGs to improve the commissioning that you're doing at the moment. One of the top things that you need to look at is actually look at your neurology population to reduce unplanned admissions. I think that one of the key things that we're finding when we go into areas is that most neurology patients are being admitted into hospital as a result of comorbidity issues that potentially can be prevented in primary care. And CCGs are just not recognising the fact that that's happening. So what we want to do, the first part of our 10-point plan is really get to know your neurology population. Look at that population and then risk stratify patient groups so that you can think about the needs of those patients in the different phases of the disease, the care that they might need, and the interventions that you may need to put into place. Certainly for our key conditions, Parkinson's, MS and multiple sclerosis, we've developed a tool called NeuroNavigator, which you can put your population size of your health economy into, and you can work out what your overall population is for those three conditions. You can then risk stratify that population so that you know the patients that are most at need, and you can work out in terms of your workforce the numbers of people that you need to support them in terms of neurology, elderly care facilities, specialist nurses, therapists. So you've got that picture at hand. You can also do a calculation of the total cost that patient group will be costing you currently if you're providing them with appropriate care, so that you can get an idea of how much you're spending within the area just on those client groups. One of the things that we've been able to identify in most areas is that you probably won't have an idea how much you're actually spending on neurology, particularly from the service that you need to provide for patients and also from an admissions perspective. So going on from that, I just want to give you a couple of examples of work that we've been doing so that you can get a grasp on some of the ideas that we've had and how we're trying to shape services. I'm just going to look first at epilepsy and try and point out to you the fact that epilepsy is ranked the 5th highest amenable cause of years lost before 75 for all males and 8th highest for females. One of the things in terms of epilepsy mortality is that epilepsy is treatable. We can prevent seizures. Mortality across the general population has been declining in England and Wales by 16%, but between 1993 and 2005, in contrast, the mortality for epilepsy has risen. We've got a population, 500,000 people in England with epilepsy. That's 1 in every 105 people. In a recent study that's been done by Epilepsy Action, 80% of people are waiting more than 2 weeks to see a specialist. 73% of people still have seizures and have not been referred to a specialist centre to manage those. And 34% of CCGs aren't really thinking about epilepsy, despite the fact that there have been cough payments for this. This is a bit of a busy slide here, but this is one of the health economies we've been working in. And when we pulled the data in that area across the providers there, we found that we got over £4 million of emergency admissions for people with epilepsy that the area didn't realise they had. Majority of those patients were having seizures and then being admitted into hospital with things like fractures, UTI, syncope and collapse. So a lot of this potentially could have been preventable. We did an audit of 5 of the practices there, and actually their practice was quite good. And they were seeing people on a regular basis. Our findings were that 63% of the patients were seizure-free. But in terms of the seizures, one of the things that we identified was that there was poor recording of seizures, infrequent medication audits, insufficient referrals to tertiary services, and a lack of information to patients about their lifestyle that might be contributing to suboptimal control. Simple things that you can do in a CCG is just use seizure diaries so that you can monitor your patients, and then they can assist GPs with assessment and treatment efficacy. In terms of annual reviews for patients, NICE recommends that we review patients annually. And we were getting patients reviewed in the practices that we audited, but there was no recording of medication adherence, and we found out subsequently that that was poor. There was no evidence of active management, and a simple thing, but no checking for if patients had collected prescriptions for their epilepsy drugs. And again, really smart options to handle things like this. There are apps that you can use on phones so that patients can be reminded about their prescriptions, picking them up. You can monitor patients through your receptionist in the surgery so that if patients don't collect prescriptions, then again, they could be reminded about them. And there are text messaging services in some areas so that, again, we can recommend medication adherence. In terms of cost savings and medication for patients, NICE guidelines recommend that monotherapy is used for patients that have got epilepsy, and AEDs are only used where additional AEDs are only used where there is seizure control is not effective. In the areas, the practices that we audited, 72 patients were taking 1 anti-epileptic drug, 5% were taking 3, and a small amount, 1%, were taking 4+. So again, there is work that could be done there with pharmacy around reviewing those patients and making sure that rather than giving extra therapy and extra drug therapy, they are referred to a tertiary centre where potentially their seizures may be controlled. Nice. What our recommendations to the CCG there have been to review all patients on polytherapy with continuing seizures, reviewing patients 6 monthly. We found that those patients that were having no seizures and multiple seizures were not being reviewed any differently. So there was a waste of time really in seeing some patients who could be potentially okay. Introducing an automatic flagging system that the receptionist could use for patients for collecting repeat prescriptions, and then pointing out some of the online tools that are available to GPs so that better adherence to medication could be used. We've also highlighted the benefit of epilepsy specialist nurses within primary care services who could provide a lot of the counselling and support that patients need in order to manage their condition more effectively. So, in terms of here, what could you do with somebody that's got an established diagnosis of epilepsy? Well, the first thing is to review those groups and do some risk stratification. Look at their medication, look at bringing other people who can help you into the equation, like community pharmacists, and then look at your links to secondary and tertiary care to improve the service, and perhaps think about using an epilepsy specialist nurse. Parkinson's, patients with Parkinson's disease were another area that we looked at with the area that we worked in here. We have to recognise that 80% of patients who have got Parkinson's disease might develop dementia, and that's a big indicator for patients going into hospital. The economic burden for people with Parkinson's is huge. If they have to go into hospital, which they frequently do if they're not managed appropriately, the potential basic cost can be between £2,000 and £5,500 if a patient's admitted through A&E. NICE guidelines for Parkinson's disease recommend regular access to specialist care for clinical monitoring and medication adjustment, education and signposting for information and support, and access to rehabilitation therapies in order to maintain independence. And if you do manage people with Parkinson's well, they can remain independent and at home for a considerable length of time. This is a disease that could last 30 or 40 years, so we want to have these people having optimal control. Admissions frequently occur as a result of complications, and once a patient with Parkinson's goes into hospital, the hospital stay is very often prolonged, simply because there's very often poor medicines management in hospital or admission onto non-specialised units. And nationally, some of the things that we're picking up is that we are getting failures of people with Parkinson's disease when they're admitted to non-neurology wards. And one of the things that we really need to do, again, is look at risk stratification and better community management of patients. This can help considerably. So again, in terms of the area that we audited, hospital admissions related to Parkinson's, well, we got 522 bed days there at a cost of £160,000 to the CCG. Unrelated to Parkinson's, 149 bed days with admissions predominantly relating to infections and falls. Chest infections cost £46,500, falls £45,000, and urinary tract infections £28,000. One practice that had a GP with a special interest in Parkinson's, interestingly had no admissions, and that was because the GP knew how to handle Parkinson's patients. But we're looking here at an area with about 100,000 patients, so this is quite an expensive area in terms of, we could have prevented this from happening. Simple measures, though, for the CCG to put into operation to try and improve the situation here is to look at a Get It On Time campaign for medication, so that if patients do go into hospital, they don't have a prolonged length of stay because they've seized up, because they've not had their medication. Looking at medicines usage reviews by a pharmacist to monitor drug concordance. Prescribing pharmacists introduced into the specialist team so that they can support better patient care. E-prescribing, where patients can be logged when they go into hospital so they're picked up immediately, and self-care and promotion and information. And some of these measures we've implemented already and seen a dramatic reduction in the number of patients that are being admitted into hospital. And if we extrapolate that across the whole economy, we can produce significant savings. So one of the things that we really want to try and think about in terms of our 10-point plan, and if you would like a copy of it, we have some here on the front row, or you can come to our pod just outside the hall here. But, patients really want to have the self-care agenda promoted to them. They really want to be independent. They really need information about how they can maintain their independence, improve their outcomes and reduce admissions. And, a lot of the things that we're providing, this is just a bit of a funny slide here, but we often put a lot of interventions in place for patients, and really all they want is simple stuff, simple information to enable them to be self-caring and independent. So I think I'll summarise here just in this last slide to say that in terms of neurology, think about your neurology population within your practices now. Look at how much it's costing you, because I think it will be a significant amount. You can always come to NCS if you wish, and we'll help you with your risk stratification. But look at what your performance is now. Try and get a profile of what's happening in your area. risk stratify your patients, promote better medicines management with them, because you will be able to reduce your costs and you will be able to improve the outcomes that your patients want. So I think probably got a couple of minutes left for questions if there are any, but thanks very much for your attention.
Well, thank you very much indeed. For that was fascinating. It always shocks me that so little attention appears to be paid to neurological conditions nationally when they're so common and so devastating. Any questions? I wondered if I can ask you whether you've been doing any work with neuropathies. I mean, as a diabetologist, obviously it's a big issue for my patients, and that can be seriously disabling.
Yes, not specifically we haven't, but again it's one of the very high spends within CCG. So when we go into an area, we'll look at where the top spends are and try and work on those conditions to improve pathways, but it certainly is an issue, yeah.
Question over here.
Thank you. Hello, my name's Lynn Morris. I'm a nurse practitioner in the Kingston CCG. Not so much a question, more of a comment really, but like many other conditions, Parkinson's in particular, services are very much of a postcode lottery. And I've found, because I've worked in the Northwest and before I came down to work in Surrey, that in particular Parkinson's nurse specialists or movement disorder nurses as part of the consultant team are very few and far between. Wondered if your service was able to help with that sort of thing or advise.
Actually, Parkinson's UK pump prime Parkinson's nurses, and there's almost universal coverage now. So it's interesting to say that you're not seeing them, but what we're really trying to do is promote integration, and we've been developing integrated care pathways in several of the areas that we've been working in. So, you know, it may be that there's not community access there, but I'm sure that there is a nurse within that area. It's just a matter of negotiating how the nurse works to make sure that they're covering the whole of the population.
She's keeping herself very secret.
Okay.
Thank you. Any more questions? Okay, well, thank you very much indeed for that.